Hi, everyone, and welcome to the Parents of Mouth Breathers podcast. Today, I'm joined by Dr. David McIntosh, an ENT specialist and an author of A Parent's Guide, Sleep Disorder Breathing, along with many other books. Hi, David. Thanks for being here today.
Hello, thank you for the opportunity.
Thank you. So, for those who haven't heard of you before or maybe only know a little bit about you, can you tell us about your background and what it is you specialise in?
Yeah, for sure. David McIntosh. The accent quickly gives it away that I'm from Australia, and I'm an ear, nose, and throat surgeon. ENT. ENT is a very big specialty, and we tend to gravitate towards a subsection of ENT that we focus on. And the one that I've predominantly focused on is airway breathing and airway health. And this then ties in with the breathing in the context of sleep. And this is where the book that you held up, that sleep disordered breathing, really comes into what I focus on. Because what I've come to appreciate and understand is that my ability as an ENT surgeon to help people can really make a huge difference when it comes to helping them breathe better, which then translates into sleeping better. And the reason I think that's important is that breathing by itself and sleep by itself, two pillars of our well-being. And this is an opportunity to actually sort of get two for the price of one in terms of helping people. So that, in the short version, that's all about me.
Okay. Well, one of the things I've been following you for a number of months now, and every clip that goes out, you can be sure I'm watching it, trying to drink up all the information. One of the things that stood out to me is you seem to be one of the few NTs, at least ENTs that I've come across, that is willing to sort of say out loud that mouth breathing isn't normal and snoring isn't normal, and all these things are sort of fobbed away with.
Mm.
Lots of parents are told, wait it out, they'll grow out of it, and all those kind of things. At what point should parents stop waiting it out? And what do they need to do to start pushing for answers? And who do they turn to first?
Yeah, great starting point. So everything has a context, and history is a really fabulous teacher for those that choose to study it. So, in terms of the outgrowing it, that's based on a huge number of fundamentally flawed moments in time, which still haunt us to this day. Because the problem is that the people that are saying that were taught by people that were saying that were taught by people that were saying that, without actually really critically appraising and assessing what's going on, and ignoring, quite frankly, the evidence and the science that's actually come to replace thinkings. Now, people have to understand, have to appreciate that medicine, which is what I do, I'm a medical doctor, medicine is forever changing and evolving. What can be right today can be proven to be wrong tomorrow. And that's not to say that we were wrong in what we were doing, because at the time it was the right thing to do, but it's no longer the case. The problem is the transition between identifying that whatever we're doing is wrong to translating it into clinical coal-face medicine has been shown to take anywhere between 10 to 20 years, which is in itself a really sad reflection on medical training, medical expertise, because we're just not keeping up. So, in terms of how we landed on mouth breathing and snoring that as a pivot point, probably the best way that I can explain that one is, rather than talk about the mistakes of the past, let's just talk about how things changed. And in 2012, there was a publication done of research in about 12,000 children. Now, these were 12,000 children that happened to be in the UK, just to give you a bit of local flavour there. And these children were under a program where they were monitored for their breathing for the first 7 years of their life. And the parents were required to fill out a survey roughly every 6 months. So 6 months of age, 12 months, and so on, roughly every 6 months. And the questionnaire was very simple. Does your child snore? Does your child mouth breathe? Does your child stop breathing at night? They wanted to get an understanding of what was happening. And if the parents answered yes to one or more of those questions at two consecutive time points, That child was put into the sleep disordered breathing category for the purposes of review and analysis. And within that 12,000 children, they found about 2,000 that fulfilled that criteria in the first 7 years of their life. There was some that it developed, at 18 months of age. There was some that developed at 4 years of age, for example. And there was some when they got it, it went away quickly. There was some when they got it, it took a while before it went away. And there was some that got it where it never went away. And what they did as part of this journey is they assessed these children in terms of their development. So at the ages of 4 and the ages of 7, they looked at how are these children turning out? Is what we're doing okay? And the short version is it wasn't okay. The children that had fallen into the category of sleep disordered breathing, irrespective of whether it had gone away or not, had problems that were persisting. Those problems were things such as learning and behavior, emotional regulation, even just simple things like being able to relate to others and make friends. The whole swathe of problems. And they found that these problems persisted even when it went away. So it's this, it went away that we need to focus on because something's amiss here. Because these children have a moment in time during their brain growth and development and really the foundation years of their future being laid down, and their breathing and hence their sleep is off track. And you only get one chance to get the brain right. And this is the moment in the time. And they weren't getting it right. So the sort of, circling back to, when should parents look at this? When should they wait? When should they intervene? The first thing is every parent that hears this needs to give themselves a little bit of self-imposed homework. They need to go and check their child's breathing at night every night for the next 1 to 2 weeks, because there's a very high chance that parents didn't know that they had to look for this and just haven't ever bothered to do so in the first place. So you go in, you don't have to spend the whole night, just a couple of minutes here or there, just mix it round to the time of night that you do it so you get a bit of a blend of observation. And if there is snoring, if there is mouth wide open, if the child is definitely, stopping breathing and choking through the night, the short answer is you're not waiting any longer. You've just found a problem. And like anything in healthcare, the best time, if you want the best outcome for your health and well-being, regardless of the condition, the best time to take action is when you find it. And what we learnt from that study, and there's been similar structured studies, is if a child has sleep disordered breathing for 6 months or more, that child's brain development is pushed off course. Now, there are additional clues that the parents can utilize. One of the big ones is the child wakes up tired or grumpy or cranky first thing in the morning. That's not normal. That's absolutely not normal. And if it's happening, you need to realize that you have a significant problem now. You've gone from a problem to a significant problem, because it's the children that wake up tired, cranky, moody, slow to get out of bed, hard to get going in the morning. When we look at the children and start breaking them up into different groups, they're the ones that have the worst outcomes of all of the above. And then you've got to look at age. So when we look at that UK study, the children that had the worst outcomes were the children where it started young. And by young, I mean 18 months of age.
Yeah.
The younger they were, the worse the outcome, irrespective of whether they, inverted commas, outgrew it. What people are observing is, my analogy is, if a child breaks their arm and you don't put it in a cast and, you just leave it to chance, that broken arm could very well heal up again in time. So the fracture went away. But what if that arm, as it heals up set in a position that's crooked? So the arm's got a bend and a kink in it. That child now has a huge problem in terms of the deformity and so forth that comes with it, and the function impairments that come with it. And then if it needs to be corrected, it's extraordinarily more involved to fix it when something simple could have been done early.
Mm-hmm.
And that's really what we're saying about these children. They're saying, well, that if, the airway problem gets better, that doesn't translate into the child getting better. In fact, the child adaptive, they compensate, they work around these problems only to have other problems down the track.
Yeah,
So that's
one of the things that stood out to me in your book is you very clearly state that they grow into it. They don't grow out of it. So they're very
yep.
much adapting. So really, the sooner the better. Get it dealt with
Yeah.
as soon as you can.
It's a bizarre conversation if you think about it, because if we were to find that you had a lump in your body and we didn't know what it was, does anyone say, well, when's the best time for me to get that checked?
Mm.
If you've got massive pain in part of your body, oh, when's the best time for me to get that checked? But we have this, and it's just like, when should I get the fact that my child can't breathe properly? When should I get that checked? It shouldn't even be a question anymore. It's a sad reflection of how off course we are when that's even a contemplation.
Yeah. Well, and for me, without going too much into my own stuff, the other thing you're navigating as well is healthcare professionals that oftentimes aren't necessarily on board with this idea that
Mm,
snoring is problematic. For example, I noticed my son, he was on the breast until around 2.5. And by the age of 3, I noticed all of these things: open mouth breathing, gasping for air,
mm,
pauses for sleep.
mm,
And it took 11 months to get a sleep study. I had to go back for multiple different opinions, people telling me that everything was fine, telling me they would grow out of it. I knew, because I was doing research behind the scenes, and my just instinct was saying that does not look normal. He's just so distressed. And
mm,
all of the downstream effects that you sort of went into there, but also that you outline in your book, that they fit my son pretty
mm.
much. So that's the added thing is, we're navigators. There's not really a question here. We're navigating this system where those drip down effects, we're relying upon professionals to be educated about this, and they aren't always.
Most of them aren't.
Yeah.
The reality is most of them are not educated in sleep. I know from my experiences being at university and so forth that training in ENT as a specialty, as a general comment, is pretty woeful. Even though ENT problems present to family doctors a plethora of times, ENT teaching and training is woeful, at least here in Australia. And I don't think it's any different anywhere else, quite frankly. So we have that compounding things. There's so many things going on around you in terms of trying to keep up. Perfect example is diabetes. When I was at university, diabetes, there were like 3 drugs for diabetes. Now, it feels like there's a new one comes out every month. And that's just one condition. I genuinely believe people are trying to do the best they can, swimming against the tide of a mountain of change and a mountain of information. But look, this is where we need to work with them, not against them. You don't know what you don't know. And that's one of the things about the book. I think I say that in the book too, is that you might find that you need to buy a copy of this book for your healthcare provider and say, look, before we have this conversation, I need you to read this book and I'll come back next week.
Hmm.
After you've read this book, the conversation we're going to have is going to be completely different.
Yeah.
This is written by a guy. He happens to be an ENT. He happens to be one of the main people that talks about this. I have highlighted and bookmarked the things that I am concerned about. And I need you to tell me that you're going to take me seriously,
Hmm.
because I cannot be reading a book written by a professional that focuses on the condition that I'm worried about and being told that everything is okay when clearly it is not.
Yeah.
You have that sort of way of being proactive. It's just one of those very difficult things to navigate because, like you said, you can have everything you need to know and then you just hit this brick wall of ignorance.
Hmm.
And that's part of the motivation for that book and the other books that I put together. It's really a way of advocating for, like you've had to do, but to try and make that easier. You can say, look, it took me 11 months to get a sleep study versus I took this book in, I came back next week, and everything just, you know, flowed on from there
Hmm.
simply because that doctor had an opportunity to upgrade their knowledge. And that upgrade made my job a lot easier as a parent.
Well, that advocacy piece, like speaking to people like yourself, is the whole reason why I've started this thing, whatever it is I'm trying to do, is because I know it's on us as the parents to advocate for our children, because we're not just going to be led towards solutions. We need to be proactive, as you say.
Yes.
So You explain in your book and you go through, I suppose the next sort of sensible question would be is why? Why do some
Yeah.
children have this and others don't? So you outline there's not one simple cause. There could be allergies, obviously enlarged tonsils, underdeveloped jaws, certain genetic factors as well, and also inflammation in the body. So for parents trying to make sense of all these factors, and this is a question that this for me really is, how do we piece it together without becoming so overwhelmed?
Yeah. So step one, realize that something's not right. Step two, why? Okay. Now, your whys are going to come more from a professional like myself than anything else that you're going to be able to dig up and find yourself. Quite honestly, you might have some clues, like you might notice that your child is prone to nasal allergies and possibly hay fever type things. For example, you might have been seen at the dentist and they've made comment about the jaws. They might even have made comments about the tonsils, for example, if they've had a look at the back. So you might sort of get those little scraps along the way, but ultimately what you need is an ENT. And again, like I said, ENT is a big specialty. You'll hear me rant and rave about this for a very good reason. And it's simply because at the end of the day, with ENT being a big specialty, you need to find the ones that do focus on these things and do understand these things. Because as you know, there's a whole lot of ENT that I do not do. And I'm aware of it. I know that I don't do this sort of ENT or that sort of ENT, but I do the airway ENT. They just need to do some of it. So you don't need to find perfect, you just need to find good. And in that context, what you're sort of looking for, is someone that works with children. Not everybody works with children. There's no point seeing the adult sinus surgeon with a 3-year-old child that needs their adenoids out. That's quite frankly, it's not what they do. It's a bit like orthopedic surgeons. You don't see the world expert in shoulders if you've got a problem with your knee. Doesn't matter if they're the world expert in shoulders, they're the wrong ENT for you if your problem is a knee. They're both orthopedic surgeons, and that's where people get tripped up. I saw the ENT. And I go, well, what sort of ENT do they do? Oh, but they're ENT. Don't they do everything? No. So that's just to highlight that there as well. And then they'll give you a lot of the what if they know what they're on about, because the big things that cause these problems. So if we start at the nose level, just starting, looking inside the nose, we have the central partition of the nose. It's called the septum. Is it straight or crooked? Inside the nose, the skin lining, is it swollen and congested? Behind all that, the adenoids, where are they at size-wise? And then downstairs, what are the tonsils like? What is the tongue like? And what is the jaw like? And that actually covers the vast majority of what we're dealing with as part of that. So it can seem very brief and quick and gosh, that didn't take you very long. But looking inside the nose and throat doesn't take very long. It just doesn't. So we actually, remarkably get very quick answers on the table as to what. And then when we know the what, then we talk about the how we're going to fix it. What is appropriate in this situation? Is this a situation where we need to look at, one thing, or as is often the case, it's a combination of things, and it's not all done at once. It's a journey because we've got to fix this and we've got to fix that. And the things that can come onto the table are medications, for example, for allergies, surgeries for big tonsils, dental orthodontic interventions for jaw issues. And then if the muscle tone, muscle programming has gone off, then there's this thing called myofunctional therapy. So just to explain that one, because that might be a bit of a novelty to people, but it's very easy to understand as a concept. Let's go back to the child that's broken their arm and then needs some physical therapy, like a physiotherapist or the like, to do some rehab because the arm's been in a cast for a while. They've lost some tone and strength because the arm's not been doing anything. The physical therapist gives you some guidance and exercises just to help get things going back on track again. That is what myofunctional therapy is when it comes to what we're talking about in terms of getting the breathing, the swallowing, the whatever else is off track, muscle function wise, just because it all gets caught up with everything else that we're talking about. And again, I know that can sound like a bit of a daunting list, and you go, all right, well, now that you're giving a list, where do I start? The majority of this, again, starts with the ENT stuff. If you see the ENT and they go, look, we've got this, 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 and this. This bit I think we can fix with this. This thing I think we fix with this. But this bit, we're going to have to do surgery. That's what you got to do. We're not running around wanting to do operations in children just because it's a way of filling our day. It's a huge responsibility that we take on as individuals to basically put ourselves in the middle of a situation where we need the parents to trust us implicitly to have your child's best interests at heart and be skilled and knowledgeable to be able to do that and get them back to you safely. You know, that I don't think people really appreciate sometimes just what a burden that decision is. We can look very complacent and we can look very laissez-faire about the whole thing. Well, that's just a reflection of two things. One, we've been doing it a long time. And two, we've got a lot of confidence in ourselves and our abilities to do this. And that's not a bad thing. You know, like you'd be getting on an airplane and the pilot goes, guys, I've been flying for a long time, but I got to tell you, every time I do this, I get really nervous. You're probably going to have second thoughts about staying on that plane. You want that pilot to go, guys, we're about to fly into a bit of rough weather, but I just want to put your mind at ease. Just put your seatbelts on. We'll get you through this. Been here, done it all before. It's going to be a bumpy ride, but we'll get on the other side and get you down safely. Just put your minds at ease as to what's coming. Then you're going to go, all right, well, you just feel better. Even if you're on that plane, that's the roller coaster. You go, all right, whoever's out the front there, never going to see them, never going to meet them, never going to know their name.
Yeah.
But, you know, it's in their best interest to get this plane down safely as much as it is mine. And it's the same for us. It's totally in our interest to make sure that we are looking after children in a safe and comprehensive manner. And that's what we do.
Well, in your book, you outlined the process really in depth and comprehensively. What happens sort of pre-surgery and the importance of not having overly emotional parents in the room, because you've got to focus and you've got something to do. And it put it into perspective for me, actually. You have to remove yourself as the parent when you are handing your child over to do what is best.
You do. Well again, you know, if you've ever been on a plane, you know, some people just don't handle flying very well. Okay. Now, again, let's go back to that pilot. So that pilot's going through and coming in to land the plane. Okay. Or taking off. So with flying, just for those that don't know, taking off and landing are the two most dangerous times of flying for a whole heap of reasons. And it's very similar to us. Going to sleep and waking up with an anesthetic, you know, in the context of things, is remarkably safe. But relatively speaking, are the two most dangerous time points. Okay. Do you want that pilot being distracted by a hysterical person while they're trying to concentrate on taking off and landing the plane? Absolutely not. And our prime interest is the child. You know, we want that we can have the parents being part of the journey and so forth, but that the parent has to also be on our side, not against us. And it's totally understandable and totally, you know, reasonable that you go in there with apprehensions and anxieties and you start having a little bit of a meltdown. Just get yourself out of the room. Don't be the distraction. And I'm not saying that to be selfish or to be mean. I'm actually saying that because we can't be distracted when we're trying to look after a child. We have to be 100% focused on what we're doing. And if there's a circumstance where, you know, and look, most parents cope just fine, but most parents is not every parent, you know, and we'll say, look, if the parent goes, oh, I don't think I can cope with this, we'll say, you don't have to. In fact, we don't want you to, because it's actually not going to be helpful for us if you're distracting us from what we're supposed to be doing.
Yeah.
You know,
and ultimately, that puts your child at more risk.
It does.
One thing that you talk about, and you explain it quite a lot, is sort of the ripple effect. Poor breathing affects everything from behaviour, obviously quality of sleep.
Yeah.
You even sort of touched on this sort of growing body of research around gut health. And so for parents who have never really heard about this sort of connection of sleep disorders, what's the bigger picture and how does it affect the child's development, broadly speaking?
Yeah, absolutely. So look, the one that I tend to gravitate towards is the brain side of things, simply because that's the one that seems to be enough to put on the table to basically shift the needle of the conversation. But there's plenty more. The problem is that we're talking about a mountain and I'm talking about a rock that forms that mountain. But there's only so much that some parents can absorb. I'm not trying to convince parents, but I'm just trying to make it clear enough that they have an understanding enough that they can just go, you know what, I know enough now just to get this over with. Whatever else is going wrong, I don't need to know about it because I'm finding this a bit overwhelming.
Mhm.
You've told me enough. I just need to get this sorted. I can see this now. I get it. So when we look at children and brain, okay, just to sort of just be quite frank and honest and somewhat blunt about it, we're talking about brain damage. This is actually what happens. And this is evident by a host of things. You can see it yourself as a parent when you understand the context of this. A child that wakes up tired and is cranky and moody and grumpy and having trouble with their learning and their behavior and their emotions, all of those things are a reflection on brain function, every single one of them. And if they're having trouble with those things, then their brain is having trouble. That's what that actually means in very simple terms. But on a more complicated level, when we go and look at this from a scientific point of view, the research has been done. We put these children we don't do this clinically, but for research, we put them through MRI machines. MRI machines are special scanners, and we can look at brain in huge, amazing detail these days. And what do we see? Well, first of all, when we take a group of kids with sleep disordered breathing and we match them for kids that are sort of, on paper look the same otherwise, the brain size, the size of the brain in children with sleep disordered breathing is smaller. Okay. The parts of the brain that control emotion and learning and behaviors are smaller. The parts of the brain that control anxiety are bigger.
Wow.
Okay. So these are brains that have changed how they have grown and developed. And that is all in a response to not breathing and not sleeping properly. Okay. So that's genuinely what we're talking about, and we can really go into the weeds. So, for example, let's say that we don't want to sort of put the child through the brain scan. One way that we can indirectly look at what's going on at the brain, looking at like the nerve cells of the brain, is to look in the eye, because the eye, when you look at the back of the eye, the little thing called the disc that is the back of the eye, that's all the nerve endings or nerve fibers rather coming into the eye from the brain. You can Beautiful thing these days, you can go and look up this little anatomy thing and sort of say, oh wow, there's actually little nerves that go all the way into the eye, and that's how we can see. We can look at the back of the eye. We can even take photos of it now, and we see those nerves dying off in children.
My God.
Okay. All right. And that's genuinely what's going on. This is literally brain damage. It's literally what we're talking about. And when we start sort of putting that on the table, that's, like I said, that's usually enough for parents to go, huh, all right, I think I need to recalibrate my concerns here
Mhm, mhm.
to this is actually, I need to worry about the problem, not the solution. I need to know when you're fixing this, not when I'm going to come around to it. And then we look at the heart and the blood vessels and the blood pressure, and that runs into problems. We can do scans of the heart, ultrasound scans of the heart in these children. We can see that their hearts are under strain and under stress, and they're not growing and developing properly. We can measure their blood pressure through the day and through the night. They have a tendency towards high blood pressure at night, which then lays the foundations for having high blood pressure in their 30s and their 40s and their 50s.
Mhm.
you know so we're trying to save them from health problems that are coming attractions now. This whole they'll outgrow it nonsense is a matter of perspective of time
Mhm.
and related to what you consider to be a resolution. And if your observation is mouth breathing versus mouth breathing gone, and that's your be all and end all, and you don't look at what has happened to this child's jaw and teeth and heart and brain, etc., not only now, but down the track, which has been done, by the way. This has all been done, and these children don't do well.
No.
And so we are basically setting them up for short term failure
Mhm.
that then down the track becomes a long term consequence. And that's not fair to the children. You
Well,
know.
you've laid all of that out, and so many of the things that you said, my son fits that unfortunately to the T, and You also mentioned in your book about sort of ADHD diagnosis and how sort of 20 to 25% of those diagnoses actually could be attributed to sleep disorder breathing.
Yeah.
My initial question as a mum, but also so many people reach out to me, most part, other British people where we're navigating this system where we're just fobbed off all the time.
Yes, you are.
Now, with this brain damage piece and the sort of the downstream effects, my child's 5 now. In his case, is that reversible once the surgery's done? And I know this sort of multidisciplinary approach afterwards, but
Mm,
is that permanent damage?
yeah. So, in short, if we look at that research study where they looked at children the first 7 years of their life, those children at the ages of 4 or 7, where they'd had a breathing problem that had gone away and they had ongoing learning and behavior problems, well, that damage is permanent. That's the reality. The damage is showing up in function. How they're functioning is a reflection of what's going on the inside.
Mhm.
It reminds me of that cartoon movie, I think it's called Inside Out, where they have the little characters that control all the brain function that's going on, whether you're angry or upset, the different ones take over controls. That's kind of what we're seeing in real life, if we think about it. So this is the concern, but let's put some positive spin on this. Children are remarkably resilient and they're still in the stages of growth and development where things can definitely change for the better if given the opportunity. So I use the analogy of a ship. If you have a ship sailing from one port to another and it has a chart that's navigated from A to B, the things that will put that ship off course and then lead to problems way down the track are the earlier it goes off course, the longer it stays off course, the harder it is to get back to where it's supposed to be. It's as
Right.
simple as that.
Yeah.
So if you have a situation where you, like I said, and it only takes 6 months for these things to start to become entrenched. It doesn't take long,
Mm.
but you give it a better chance, and then you get the chance for the brain to then go, okay, I'm going to rewire now, and it will. Then you can get yourself back to where you need to be. But it really just cannot emphasize enough that people have two mindsets. One is they'll outgrow it. That we need to throw that one out. That one was thrown out so long ago,
Yeah.
so long ago. It has no place in this conversation.
Mhm.
The second one that we need to dismiss and just move forwards from is oh, they're too young. Okay.
Yeah.
They are too young to have a problem. They are not too young to have it fixed. In fact, the younger they are, the quicker it needs to be fixed. It's totally the opposite because 80% of brain is done by 2 years. Think about that. 80% of your brain growth is done by 2 years of age. You don't have time. That
No.
brain is not going to wait for you to get things better. That brain is going to adapt and rewire itself every day, specifically though every night. And this is why, for example, when we look at these brains of these children and we see the stress part of the brain, it's called the amygdala, and it's bigger. So I'll have parents come in and say, look, my child snores, they're waking up tired, cranky, we're having problems at school. And I'll go, all right, is there anything else going on? I said, oh, yeah, look, I know it's not related, but they're being managed for some anxiety problems. And I'll just go, well, actually, it is related. And they go, what do you mean? You go, well, your child's anxious, all right? That's not an unusual thing for a child to have to deal with. And look, there could be life circumstances, but in general, that's not normal. What do you get good at? Like, if you want to get good at playing the piano, you have to practice a lot. And then over time, the brain is what you're basically rewiring to be able to play the piano. Now, what are these children doing when they can't breathe properly at night? They're going into stress mode. So, which part of the brain are they training? The stress part of the brain. So, what overflows into the day? Anxiety. Why? Because that part of the brain is actually really good at it.
Right. So they're becoming conditioned to being more. So yeah. Oh my gosh. Yeah. It's very it's sort of well, it's very frustrating hearing you talk because it just brings back some of these experiences that I've had, i.e., when we had the sleep study, I was told the results were really mild. And you said something really interesting in your book about sleep disorders. Like does it make a difference if you get hit by a truck or a car? You're still getting knocked over by something.
Yeah.
This whole idea of things being mild or severe.
Yeah. Has anyone ever suggested to you that you're mildly pregnant?
You're either
Okay.
pregnant or you're not. Yeah.
Correct. Okay.
Mm.
Have you ever heard of a case of mild cancer?
No, no.
Right.
Cancer.
All right. Yeah. Okay. So we're dressing this condition up with words that make it sound like it's not as bad as it is, on a rating scale that actually has been proven to be absolute nonsense. When we look at this rating scale of severity, it's what's called the AHI, the apnea hypopnea index, and it was created by a scientist in the United States purely for research purposes. It was just a way of measuring things for research purposes. It was never intended for clinical use, never. But what happened is that in the US, American insurance companies adopted it as a stratification of disease severity to work out what they would and wouldn't then pay money towards.
Wow.
I wish I had never created it. When we look at it critically, when we scientifically look at it and say, how well does what we're measuring relate to the individual? It doesn't relate very well at all. Founded upon a measurement that the person that actually created it says he wished he'd never done it. All these things are man-made. This is all made by the human race, these systems and rating scales. And this one in particular is entirely made up. It was made up for research purposes, which is not unreasonable. If you're going to do research, you want to have some way of measuring and categorizing things, helps you understand things. That's not the same as using it in a clinical sense to drive and direct your care. But that's what's happening.
What I was told with that AHI thing was that, number one, that's how children are prioritized for surgery. The higher the severity, the quicker they're put through for surgery. But also, one of the things that I've tried to fight for and I can't get is an adenoid assessment. My son's scheduled for a tonsillectomy, but they won't check his adenoids until he's actually in surgery.
That's not unreasonable.
Fine. Yeah. Okay.
If the tonsils look all right, you really need to know what those adenoids are doing. But if those tonsils are already on the table, in a 3-year-old, quite honestly, it's much easier just to have a look when they're asleep. There's certain anxieties and stressful moments that you can just put to the side and use the anesthetic as your guide. But again, just reflecting on that, you had to wait 11 months.
9 months for a sleep study, and since that he was put forward through surgery, and we're 18 months into the wait.
Can you start doing the math on the problem here?
Yeah.
You had to wait a significant amount of time to basically have a test that, by the time it was done, has basically opened the door for your child to continue to get worse, just to then be told that, okay, he's not good and we're going to fix him.
Yeah.
I can't fix the UK health system. I hear it all the time. And in terms of first world countries, I think you're pretty much the lowest rung on the ladder in terms of where everything's at. But that's probably just a reflection of system problems across the board from what I can gather. I've been doing this for 20 plus years. In 20 plus years, the number of times that I have needed a sleep study in a child to work out what's going on is less than my fingers and toes combined.
Really?
The sleep study will tell you if they've got what we call end-stage disease, okay? So end-stage disease is sleep apnea, okay? All right? So if your child is just mouth breathing, sleep study's normal. If they're just snoring, sleep study's normal. If they're struggling to breathe, but they're physically strong enough to overcome the resistance to breathing, normal sleep study. Now, those 3 things I mentioned are not normal breathing. So this is where, again, parents get tripped over. A normal sleep study does not mean normal breathing. All it means is your child has entered into end-stage disease. And then when we talk about mild, moderate, severe, the context of that is it's mild end-stage disease, it's moderate end-stage disease, or it's severe end-stage disease. So that's where people are not understanding this terminology and applying it properly.
Yeah.
They've got severe bad disease. It's all bad, It's just a graduation of mild, moderate, and severe badness, which is a ridiculous scale to be working off of. And that's what I said. The person that invented this wish he'd never done it.
Yeah, well,
Because
he was diagnosed with mild sleep apnea, but
yeah,
my argument as well was this sleep study basically consisted of us picking up the sleep monitor. We weren't allowed to hire one privately and use that. They wouldn't have used the results. So it was a 5-hour window overnight that
mm,
it recorded him for, and they
yeah.
made the whole decision on that. And they were even on the fence about surgery at that point.
And all I do is get the parents to video it. I just say, look, go watch your child and just video it.
Yeah.
Bring it in. Show me what you're hearing. Show me what you're seeing. Look at it and go, when are we doing this?
Well, you seem to be an outlier compared to the ones that I've met. And certainly in the opening of your book, when you talk about telling a little girl that you've been for a swim and you were talking to the mermaids or whatever it was, I thought, oh, God, that's so warm and inviting and accommodating and compassionate compared to sort of the very impatient ENTs that we've been to see, unfortunately.
Yeah, look, part of the background is as much as you're dealing with the parent, the reality is you're dealing with the kid. The parents are the people making the decisions, but the child is the one that's really involved with the consequences of the problem and the solution.
Okay.
So, and to get to that point, you've got to get the kids on board. The majority of my day is spent hunting unicorns, dinosaurs, and crocodiles.
Yeah.
Now and then we have to swap to mermaids and Pokemons and, whatever else is on the table that the kid's more interested in. That's what I do. And that's part of the process and the magic of it all, is that we've got to get these kids dealt with at a kid level in terms of the types of conversations we're having with them. There's no way, I'll tell you, you cannot explain to a 3-year-old what's about to happen.
No.
There's nothing in their world life experience that even, that they can relate to and so forth. So you might as well just put it on their level and just turn it into a story and a bit of an adventure and a bit of an experience. Because if you try and explain to a 3-year-old, look, you have to wear these clothes and you have to lie on this table and they're going to put a mask on you and it's going to be really smelly and so forth, but you have to do it because I said so, it's just not going to work.
No.
There's, I say this, somewhat flippantly, but, it's much easier to negotiate with a terrorist than it is with a child, simply because at least the terrorist knows what they want.
Yeah.
You cannot negotiate with a child.
No.
And they're coming into a foreign place. They haven't been allowed to have anything to eat or drink. And they've been taken into this place. Like, it's all very like, what have I done wrong? Sort of moment. So if we can turn it into a game, turn it into an adventure, going in and we're going to go and hunt for unicorns and dinosaurs and, here's some stinky stuff. Oh, the unicorn did a stinky fart. We just try and break it down as best we can to child level, just to get them through that moment. Ultimately, once they're asleep, off we go.
Yeah.
And once they wake up, all right, look, things aren't great. That's when they realize that, all right, we sold them a bit of a dud in terms of everything that's about to happen, but we just got to get there. And that's all part of the challenge and the fun of dealing with children at the same time.
Well, and I can attest as somebody that had both my tonsils and adenoids removed when I was 6 that I don't remember anything.
You probably have some vague recollection that you scored 2 weeks of ice cream and didn't have to go.
Yeah,
So again, it in the moment at that very time, it's not great, but it passes.
Yeah.
It passes.
Okay, so a child's gone into surgery. I know in your book you go into sort of some of the risks of surgery, which we won't go into now, but primarily it's bleeding, but in rare cases. How do we as parents, and this is imminent for me in the next 3 weeks or so, my son's going to be called for surgery. What do we do in the aftermath of that to not only help them recover from the surgery itself, but you touched on earlier dental work, things like myofunctional therapy. Is that the order of things, generally speaking, that you would say ENT, dental, some sort of therapy?
Yeah, look, it's horses for courses. You should have a plan mapped out by your ENT already. So, for example, if I've seen your child and go, look, here's where we're at. We're going to get these tonsils out. I'm not sure about the adenoids. They wouldn't cooperate on the day. It doesn't matter. I'll be able to get a good look when I'm there. And if it needs doing, we'll just get that over and done with. I also need to draw your attention to the fact that this top jaw is already not growing properly. And because it's not growing properly, before we even get the surgery done, if you get an opportunity, pop in and see a dentist just to get things assessed. Not that we're going to do anything yet, but I just want a baseline So because 6 months down the track, I want you to get another assessment. And the reason we're going to do that is I need this dentist to monitor this jaw growth. Is this jaw growth catching up now that we've dealt with the ENT stuff, or is it lagging behind? And if it's lagging behind, is it something then that we might need to start doing some early things on? In the meantime, 3 months from surgery, the breathing and sleep should be on par. If there's still mouth breathing, despite the fact that I've got things sorted, still snoring, despite the fact I've got things sorted, then we need to look at myofunctional therapy stuff along the way. And those allergy things that I'm pretty confident we're going to be able to manage with simple measures. If they happen to escalate, you need to come back and let me know.
Okay.
That's the sort of conversation that a parent should have had.
Okay.
So that way you're not having to work out what to do. I've just laid it all out for you. Explain, the pecking order of things and also the, all right, coming attractions.
In lieu of those conversations happening with the professional, because I know in my case, I don't have faith that that's going to happen. I have been to see lots of independent, private practitioners, an airway dentist, Dr. Ether, who I think you'll be speaking with tomorrow, and also a myofunctional therapist. So what I think you're saying is a multidisciplinary approach is key in all of this.
In cases where it's complicated, some things are really easy, and this is the problem is that, what is going to work for your child is going to work for some other children, but not all of them.
No.
And this is where you have the best of intentions, but you don't get the best of outcomes, because if your journey is, I just needed tonsils and adenoids out and that sorted out everything, the next parent that hears that story might think, oh, that's all I need to do. But that's not necessarily the case.
No.
And likewise, the parent that hears that I had to go and get the surgery and I had to go and see a dentist and I had to go and see a therapist and I had to go and see an allergist, and the parent hearing this is going, oh my God, I don't think I've got the time or money to do all of this. But they may not need all of those things done. When we talk about things, we do so generically just to cover our bases, just so that there's an understanding of the potential touch points along the way. But it's very, very nuanced and very, very individualized as to each child on their merit as to what's going on. As it says in the book, we can be dealing with adenoids in a 3-year-old, and then they turn 8 or 9 and they start to get nose allergies. Well, okay, we start dealing with that then. It's no different to if your car needs tyres changed every couple of years. I had my tyres changed 3 years ago and now I need them fixed again. So that last tyre change didn't work. Of course it worked.
Yeah.
Oh, I had surgery and then they got problems later on. Well,
that really reflects a lot of the sort of anecdotes that people share in Facebook groups and the like. You know, you've got some children who a few months after surgery, the original symptoms are coming back. Other people swear that surgery changed everything for their child for the better. And I think it's that piece, with my son, unfortunately, does fall into all of these brackets. He's not only got the sort of enlarged tonsils and whatnot, but he's also got the overcrowded teeth and the setback jaw and all those things. So his treatment is going to look different to somebody who just needs.
Absolutely.
Okay.
Yeah.
Awesome. Well, thank you again. It's been really good to speak to you. Is there anything in particular that you would like to sort of leave with us as the final word?
Look, I mean, there's so many things we could say, but my experience and so forth, I think at the end of the day, rule number 1, listen to the parents. All right. You get the movie, we get the snapshot. Okay. You see what's going on. Rule number 2 is listen to the grandparents. Okay. Because, it's not unusual in the way things are structured these days that the grandparents are providers of care for the children as well. And, some of these grandparents are pretty cluey. It's not unusual. Like you said, you've had your tonsils and adenoids out. So they've had some sort of life experience and they might see the same thing in the grandchild and they go, oh, they take straight after you. We got yours out when you were 6 and we wish we'd done it when you were 4 when it first started. So go get them out now. Don't muck around. Listen to them. Because if they've got that life experience that they've seen this show before, they've seen this movie, you don't need to watch the whole thing play out to decide that you need to pause and fix things. So I always think that listening to the parents and listening to the grandparents is enormously beneficial. And the second thing is, look, if you're worried, then you're right. I can't tell you that you're worrying about the right things, but you are absolutely right to be worried. If something is not going well, something is not on course, you are absolutely within your rights to be worried, and you are fully entitled to get a full and thorough explanation as to what it is. And if in this context you are, like you said, fobbed off, don't take no for an answer.
Mhm. I like that. That's a good line to finish on. Do not take no for an answer. Thank you. I will pop all of Dr. McIntosh's or David's book and resources in the show notes. And yeah, again, just a really big thank you for spending your time with me today and putting
Absolutely.
some of things at ease for me with
No,
my son's surgery.
absolutely.
Okay, thank you.
Cheers.